If the hospital nurse talks to the long-term care nurse, then that would help. So any of you have ever taken a report from the ER to the ICU or from the hospital to long-term care? No, we're lucky if they get the gender right. So it's just incredible. But if the chain of custody, that's reporting, prescriptions, from facility to facility, physician to physician, if that's broken or doesn't happen, there's a huge opportunity. Appointments, follow-ups, not communicated, again, communication, risk management. Why do people come back to the hospital from long-term care? Because if they have a change of condition and the nurse calls the attending physician, what does the physician say about altered mental status or change of condition? Send them out. That's the common language. That's language that's cultural. It's historic and cultural. There are two reasons doctors give. One is, well, we can't do what they need in the nursing home. They need to go to the ER. That may be the case. But the other reason is risk management. If anything happens in long-term care, get that patient out, get a big assessment, show we were quickly responsive and an advocate for that patient. Is that what the patient wants? Is that what the family wants? So an abnormal anything, a condition change, mental status change, anything that's abnormal in the long-term care or in the community may be a reason to readmit the patient to the hospital. And family concerns and demands. You know, 911 is at home, so if grandpa changes, 911, they go to the hospital. The family comes to the long-term care facility, they walk in the room and say, oh my gosh, look how she's changed, nobody called me, get her to the hospital immediately. Any of us who have worked in long-term care have had that experience where the family walks in, they're shocked by something, and want us to send the patient out. And I think those are some of the causes of readmissions. Do you think of others? Causes of readmissions? I think I've captured the edges of most. So, readmission reduction. What works? What keeps people from being readmitted to the hospital? So, medical professional visits soon after hospital discharge. I think all of us know that if a medical profession, a physician or a physician extender, a non-physician professional, sees the patient in the community or in long-term care within 14 days, it decreases the readmission rate by some 20%. So a medical professional visit after discharge has shown to make a difference. Seamless communication and handoff. If we really are able to communicate reports and what happened through the hospital stay, then we can do a better job. Continuous treatment plan. If the treatment plan is appropriate to finish a course of antibiotics, to do wound care, if it's goes all the way through long-term care, we can reduce readmissions. Identify clinical follow-up measures. Measure the hemoglobin. Measure the calcium level. Measure those things that we can modify and improve in long-term care, and the patient may not have to go back to the hospital. Ask the patient what's important to them. Do you want to go back? And if the patient can't tell us, I've had a family, I've learned this, a couple of families, when I say, well, what would your grandmother say? She's unconscious, she's got Alzheimer's. Are you nuts? She can't tell us. So I don't let it be that grandmother. I would say, you know that grandmother that ran her life and yours, the whole family, the county, that taught you how to make peach cobbler with that cinnamon sugar on the little top? That grandmother who told you when you went to the prom there was not enough dress and too much of you? You know that grandmother? If that grandmother could sit right there decisional and she could say, what's most important to you today? Is it to go back to the hospital or is it something else? And that's the principle of substituted judgment. If they can't tell us, we ask. If they cannot tell us, then we ask the family what that person would want. So readmission predictors, how do we know who's going to be readmitted? Well, how do we identify at-risk individuals? LACE is one of the new methods. It's intuitive for us in long-term care and in hospitals. If a patient is in the hospital and they have a long length of stay, then they're more likely to come back. The acuity is the A. Were they admitted electively or through the emergency department? That's a pretty easy score. If they came through the ER, they have higher acuity. The C is for comorbidities or complicated health issues. The more systems involved, the more complicated their diagnosis are, the more likely they are to come back to the hospital. And the E stands for how many emergency department visits have they had in the last 6 months. So if somebody had a very short length of stay, they were admitted electively for an IND of an abscess, incision, and drainage, and they only had diabetes and hypertension, and they had no ER visits in the last 6 months, they'd be a low LACE score and a low likelihood of readmission. But if they're 85 years old and they've already been in the hospital 14 days and the last 5 are in ICU, and they were admitted to the ER and they have multi-system disease and 3 ER visits in the last 2 months, not 6 months, you know those people are going to be readmitted or die. The Palliative Performance Scale, I talked about you being 100%, and at 40% people go to long-term care, but they continue to decline. We know about Interact 2. Dr. Oslander, a nationally famous geriatrician right here in Florida, down at Florida Atlantic University in the geriatric department. He has been developing this and providing it to us for 20 years. There are proprietary, very expensive, $100,000 a year for the Milliman. But it will give you, for this person with this history on these medicines and their environment, they have what % chance to present to the ER within the next 2 months. It's incredibly predictive, but quite expensive. And professional intuition. I will tell you, if you have case managers, because we don't call them discharge planners anymore since I made that bumper sticker joke, they won't use that name. But the case managers now, they will say, we're going to send this lady to rehab. And I said, do you think she'll be back? Oh, tomorrow. But at least she'll be discharged today. Our professional intuition, which is experience, knowledge based on experience, you can tell that they are coming back. So if we can predict who's going to be readmitted, what can we do? Well, we can vaccinate them. If we know who's likely to be readmitted, then we can either solve their clinical problem, have the visit. If our intuition is they're going to be readmitted, then in our environment, long-term care, fix whatever it is that would cause them to be readmitted. Hypercalcemia, hypotension, a wound, or ask them or their family, what's most important to them today? Is it to go back? Did your loved one have a great comforting experience the last time they were in the hospital? And it's probably not when they come from long-term care. Ask them what's important. But if we can get ahead of the emergency, send them out. What's important to the patient? What are the goals of care? What are the goals that person would tell us, the kind of care they want, not for the end of their life, because that's negative and it stops the conversation, but for the rest of her life? What would your grandmother tell us? That peach cobbler bacon grandmother we talked about, what would she tell us would be the kind of care that she would want for the rest of her life? Would she want to go back to the hospital? And if the answer is yes, she gets to go. But if the answer is no, can we find a way she doesn't have to go back to the hospital? Principle of substituted judgment, if we ask a daughter, as a younger geriatrician, my patients used to be 70, their children were 45, so we're 45-year-old people during the day, they're at work. But today, my patients are 95 and their children are 72, and where are 72-year-old children? On the elbow of a geriatrician driving us nuts. That's the trouble with geriatrics, the patients are too old. So we would ask, when your mother was cognitive, when she could tell us what she wanted, did she? Can she? What would she want? What would she say is the best care? No coercion, no direction, no goal except to respect that person and what their wishes in their life would be. What their wishes and readmission is not in many people's life plan. So, thank you for letting me open for those minutes, and I want to go on. So you got cards if you want to write comments for solutions would be appreciated, but if you have questions or thoughts, you can certainly write those down on a card. And Dr. Sussman, did you want to introduce? You want to just pass it along? No, please. Dr. Foley?
Thank you, Dr. Hawk. I appreciate those comments. Always entertaining. I'm writing down the jokes as you tell them.
This is life and death.
So next up, we're going to have the folks from HSAG, I'm not sure on the order, but Edmund Clifton and Amy Osborne to discuss the impact of end-of-life planning on preventing avoidable hospital readmissions.
I'm coming.
Good afternoon. I'm going to be fairly brief. I'm just going to show some slides, some community data, and how that